Hello, I'm Violet Krayshak, and I am pursuing my Master's of Public Health. This video is for a course, Public Health and Mental Health, and I will be interviewing a few different stakeholders who work with homeless populations and people dealing with severe mental illness in Milwaukee, and looking at that interconnectedness of homelessness and mental health.
My name is Ryan Honig. I work with the City Milwaukee Health Department as a data evaluation coordinator.
My name is Liliana Richard. I'm a nurse, a registered nurse, and I've worked in public health for the last 10 years.
My name is David. I'm a psychological associate. I'm completing my doctor's in clinical psychology, and I'm working as a resident at probation and parole, and also the institution, so Department of Corrections.
My name is Emily Kenny. I work at Impact. I'm the Director of Systems Change and oversee our coordinated entry system for Milwaukee County.
As a local health department, has a wide variety of services, both like working actively in the community and also like at the structural level.
So we provide system coordination and client assessment. We're the beginning point for people who need social, family, or health services, and then we coordinate systems to make sure that they get access to those services. So the coordinated entry system is the system for how people experiencing homelessness get into and through from, kind of street outreach, homelessness prevention, all the way to permanent supportive housing.
So as a registered nurse, I've worked in different capacities for serving our community. I've worked in the hospital, I've worked in the in home nursing, home health nursing. I've done some case management for long-term care funding programs. I've also worked in the correctional setting, incarcerated setting. That's where I currently am, in addition to a mental health emergency center. In all of the nurse jobs that I've had some contact with people who have not been sheltered or have extreme vulnerability to being close to becoming unsheltered or homeless.
I'm working for the Psych Services Unit. They provide psychological services, which include diagnoses, psychological assessments, intervention, treatments. We collaborate with psychiatry and health services. We do rapid interventions for suicidality and essentially allow individuals struggling to try to better adjust to a really difficult situation, which is prison. At probation and parole, I work with probation and also the courts. So I provide psychological evaluations. I also assist individuals essentially managing their health care and also psychological care to try to get them to best succeed in probation and parole. So that means getting them services, therapy, medications, kind of being like a liaison between all those. As a paramedic, that's also a huge overlap with essentially when you have no access to healthcare, that's kind of your last resort, and individuals with mental illness or have become homeless don't typically have primary care or even any sort of access to any sort of healthcare, so the last resort is calling 911.
We've cut homelessness in half since 2015 in Milwaukee County. For the pandemic specifically, we noticed a dramatic decrease in street homelessness because we had additional and really customizable, flexible, temporary options for people who are outside to come inside due to COVID funding. That has now trended back up because that funding has ended.
The homeless population is aging, so there is a higher proportion of the aging population who are homeless. Black males over the age of 60, probably the most vulnerable group for structural and just their own individual reasons.
There's a disproportionate number of people who are Black and African American that experience homelessness to the population in Milwaukee County, and that population actually takes longer to get housed.
I think inequality, unfortunately, can be viewed through a racist kind of lens. Segregation in Milwaukee's been pretty prominent, and decades of redlining and lack of access contributes to inequalities in especially Milwaukee. And I think that long history in Milwaukee of inequality contributes to just a systemic funneling of people that don't get the extra help they need, or have barriers actively preventing them to succeed that can contribute to becoming homeless.
People using opioids has become a higher number of the unsheltered population, and also mental health, people experiencing acute mental health crisis or a chronic mental health.
I think one of the biggest challenges is that we have a high poverty rate compared with the rest of the nation, and so because of that poverty rate, that impacts housing quality, housing stability, and therefore mental health quality and stability. Violence and the rise in violence in our community is directly related to feeling mentally well.
As a paramedic, you often see individuals who are homeless that have no other hope for any sort of treatment. So if somebody has a tooth that needs to get pulled, they don't have access to a dentist, so they have to call 911. And it's unfortunate that it has to come to that, but if there's no other resources, that's the only one left. And I think it's a really ineffective and inefficient way to treat people, and it kind of makes people reach out to a service that's not intended for that, but because there's no other options, they need to use 911 for primary care because there's no other steps between that.
For follow-up appointments, they don't have access to transportation. They're not always in the same area, so pharmacies become difficult. They're focused just on the day-to-day of like getting by, understandably, when they're just trying to survive. Often don't have cell phones, so like we can't get the reminders that people usually get for their appointments. They can't call or reschedule. And also too, I think that definitely brings a stigma with it. Not even just being homeless necessarily, but being non-compliant or like missing appointments and things like that.
50% of the population self-report that they have a mental illness, and so certainly working through that and figuring out how we treat people experiencing mental illness is a piece of solving homelessness, particularly in housing stability. So, getting somebody housed, but then making sure that they can keep that apartment. And so we work really closely with the behavioral health services. We have people who are licensed mental health professionals in our, within coordinated entry and on-street outreach teams directly.
It's always going to be hard with mental health because it is such a sensitive topic. I mean, in terms of taking one's autonomy away from themselves by forced hospitalizations or forced medications, it's really not where I see us going as a society. I don't think that in the long run is as sustainable.
I think prevention is by far the best route for anything specific to psychological services. Unfortunately, the agency I work for doesn't get involved until you are a part of you've committed an offense. Thankfully, they put a lot of resources into probation and parole. So I think they're working on, especially when it comes to drug offenses, getting access to services that otherwise were not accessible in the past. But I think you should not have to get arrested to access those services. I think at that point there's been a lot going on, and the earlier you start and the most resources you start with, so child starts with MPS, you need to add more resources earlier on to prevent issues.
When someone is in an acute mental health crisis, they don't always voluntarily seek the support for it. And research has shown that the more the longer and the more frequent destabilizations or episodic like manias, the worse it's going to be for their overall health and prognosis with their disorder in terms of schizophrenia or bipolar. So the goal is really to keep people stable.
It's not unidirectional. Some people become homeless due to like severe mental illness where they're unable to manage their own activities of daily living, unable to pay rent, work, things like that. And when they don't have the sort of like structural support, that will definitely lead to them becoming homeless. And then people who are homeless, will say for different like maybe purely like economic and like social reasons they become homeless. That is very traumatic. It's destabilizing. It's unsafe in many ways, which can really lead to deterioration of one's mental health.
Severe mental illness really exacerbates our instability in life and our difficulty kind of getting access to steady employment and a house, a car, family that stays to kind of support like a whole family unit. I think upwards of like 40 to 50% of individuals with severe schizophrenia end up homeless at some point in their lives. And I think that really highlights how mental illness and homelessness are almost a symptom of our environment.
We do know that homelessness has been empirically found to be traumatizing and then exacerbate mental health.
It's hard to treat somebody for depression who's homeless and talk your way out of depression when you don't have shelter or you don't have health care or you have mental health needs that are not being met or medications that you're not taking. So I think that this is where things like our environments play a far greater role in the expression of our psychological symptoms than any treatment can really address.
So if we look at mental health disorders such as bipolar or schizophrenia, which are thought and mood disorders, when your reality becomes so complicated and unstable inside your own mind, it becomes then very hard to create a stable environment around you.
Oftentimes, mental health, unfortunately, is sort of a symptom of our environment and also despair. And I think because I work with the Department of Corrections, I see people that are really kind of had really tough upbringings, tough lives, and I see that expressed in a lot of different psychological ways, and one of them being, mood disorders, chronic mental illness like schizophrenia, among a host of other issues that are typically exacerbated by difficult environments.
This is a very interesting time for Milwaukee, having had the mental health complex, which historically served so many Milwaukeeans with mental health disorders for so long, is no longer in existence.
These problems persist, but in terms of, if you look at like national research, we have state-of-the-art systems for both behavioral health and homelessness. Milwaukee was the city in the nation to get the lowest per capita street homeless count last year, and so we have a lot of strengths in our staff.
Working together, we have the resources that we need. We have people in the community who are doing great work and who know what they're doing and that they're seeing successes.
We have a number of vacant units and actually a lower kind of housing cost than other communities. Housing quality is not an asset, which might be part of the cost part of that.
I think it's shocking how many people with pervasive and persistent mental illnesses become homeless at some point. And I think we often kind of kid ourselves that things like free outpatient clinics or some resources or rides to and from facilities is enough when somebody is unhoused. I mean, we can do something for 1 hour a week, but if that person is in the elements for the rest of that time, we're not really doing anything.
There's definitely a high enough number of services in Milwaukee County, but I think a lot of it is the coordination and like the efficacy of these programs, given their structure. So like how they intermingle and how they work with people who are outside of the behavioral health system. I think it's really important, something to look at. It's something that we are always pushing to change.
Honestly, I think the most important thing that we need to do right now is find out who's doing what they're doing well, and get us all to work together. I think we have some great community support programs that are having great successes. Some of them, though, are understaffed, underfunded. We need to show our support there. We also need to connect them with the other housing resources that we have in the area, as well as the acute mental health stabilization.
Coordinated entry became a mandate in 2017, and we implemented fully that year. I think that the asset is that we bring agencies together. So instead of us each trying to solve homelessness or mental wellness on our own, we have to do it together. Behavioral health division did a study with the housing division in 2015, and in 1 year we saved $700,000 of taxpayer dollars to the behavioral health system because people were housed.
What I used to think a lot when I was working in the emergent mental health setting, we can only keep people stable in the hospital with medications as long as they're in the hospital. Once they leave that acute setting, we are no longer able to keep them stable. And that goes for their mental health, but that also is a reflection of then their homelessness. Where the efforts really need to be focused and where I've seen the most success are in community support programs that keep people stable in the community that they live, so they don't need to have these short-term acute stabilizations, which then get released back into their regular life with no supports around them. So there are certain programs called community support programs that pair a person with a severe mental health need with resources such as a social work case manager and a nurse to handle their medications. And I've seen that be very successful when it's in combination with housing resources.
What we are missing with Housing First, we have low barrier entry to housing, but we don't have true wraparound services. Not the way it's supposed to be implemented, not the way that the research says it works, and that directly relates to mental health. If we invest in those social service supports, that we'll see another drastic drop.
These community support programs that can provide a secondary level of care might not be as acute or as in an inpatient setting, but it's more support than just outpatient clinics. It's kind of meeting the demographic where they're at and where they need the support.
What would make our community more well is if we had a robust housing justice policy where people were able to have stable, safe housing. And then even if they're, struggling with mental illness symptoms, that they would be able to keep that apartment and not being housed as a consequence of mental health symptoms.
I have personal experience with this population. I have a brother who has schizoaffective disorder. He was diagnosed at 19. From 19 until 28, he was either homeless in jail and incarcerated setting, different family members' houses, using street drugs, not being medically managed for his schizophrenia. It not only cost our family a lot of strife, it also cost the system and jail stays and different acute hospitalizations. And that was the first 10 years. But for from 26 until now he's 36. He's been stably housed and not been in jail or an acute hospitalization, which has saved a ton of money and also saved his family and given him a better quality of life. And this was because he received funding for stable housing that the Milwaukee County Housing Division runs, in addition to having a community support program that pairs him with a social worker, psychiatrist, and nurse. This keeps his basic needs met and helps him manage his mental health needs. I don't see why this wouldn't work for, or I guess I should say, I've seen this work for many other people. However, the funding is limited for these type of housing situations and for these community support programs, but we know it works, and in the long run it will save us money, will save the family strife. So I will continue to work towards those.